Good afternoon. Welcome, everyone, to the webinar, Thriving in Substance Use Disorders, Service Delivery in the Post-COVID Era. And as many of you know, this is a training brought to you by the Center for Substance Use Training and Telementoring, CSTAT, a division of the Be Well Institute, in collaboration with the Texas Health and Human Services Commission, with the intention of exploring the intersection between COVID-19 and substance use disorders. And to that end, we reunited a group of leaders in healthcare, such as behavioral health professionals, prescribers, psychiatrists, epidemiologists, and many others, to bring to you the most recent information on COVID-19 trends as they relate to substance use disorders. But before we start, I want to remind you that this session is being recorded for later distribution, and you may find it later at our Be Well Texas YouTube page. There is a Q&A box in front of you. We invite you to use that space to add all your questions, and our speakers will address each one of those at the end of their segment. Today, we have officers John De La Garza and Samuel Guzman. They are from the San Antonio Fire Department, and it's a pleasure to have you with us. Welcome to the webinar. And I think we're ready to start sharing your presentation. And again, welcome to the webinar. Thank you.
Good afternoon, everyone, and thank you, Andrea, for the introduction. My name is Lieutenant Sam Guzman. I am in charge of Mobile Integrated Health here in San Antonio for the San Antonio Fire Department. Next slide. So a quick disclosure before we get started. All speakers and all members of the Planning Committee have no relevant financial relationship with a commercial interest to disclose. The viewers and opinions expressed by participants and speakers attending the webinar series are solely their opinions and do not reflect the official positions or policy of UT Health San Antonio. This webinar series is supported by Texas Health and Human Services Commission through federal funding through SAMHSA, grant award number HHS 0010423000006. I believe I hit all those zeros there. Next slide, please. Couple of objectives for this presentation before we get started. So I will explain San Antonio Fire Department's MIH model, the components of that of our MIH system, all of our programs, and how you may be able to utilize that to cater to your local needs. We'll also evaluate the strategies and lessons learned during COVID that made our operations stronger and enhance those operations. And then I will turn it over to John De La Garza. He will go over OPCR, Overdose Prevention Crisis Response, and the poly-OPCR programs and highlight contributions addressing substance use disorders, or SUDs. Next slide, please. So what is MIH? Mobile Integrated Health is what it stands for. It's a non-traditional way of using traditional firefighter paramedics to work in a proactive manner to reduce unnecessary 911 calls and/or unnecessary ER visits. Quick overview of our fire department. We're the 7th largest city, San Antonio. That's the 2nd largest in Texas. We got a population of about 1.5 million. We currently have 54 stations, 54 engines, 21 ladder trucks, and 46 ambulances. All this to be said is that the city is continually growing, translating to higher call volume, higher responses, higher unnecessary 911 calls, and unnecessary ER transports. Next slide. So after pulling data from 2013, considering all of these unnecessary calls that were coming in, we found that at the time, 16,000 patients that were marked as HVUs or high volume utilizers had called a total of 47,000 times that particular year, which resulted in about 28,000 unnecessary transports. So the city found that there was a need to do something about this in October of 2014. We birthed our first program, which was our HVU program. It was a pilot program, and due to its success, 2 years later, it became permanent as of May 1st in 2016. Next slide, please. Quick overview of all of our programs. We currently have 10 programs, all of which are designed in some form or fashion to alleviate unnecessary 911 calls or unnecessary ER transports. And next slide, please. Current staffing, we have 14 medics total, 10 assigned on a Monday through Friday 40-hour schedule, 40-hour work week schedule, 4 assigned to our 24-hour unit. They're on an EMS schedule. We have 15 additional members that work for SA Core. They are also on a 24-hour EMS schedule. You probably are asking yourselves, well, how does 30 people do what we're doing with 10 different programs? Well, along with that, we have 183 MIH alternates. These are folks that work in the EMS and fire division. They come in on their days off on overtime, and they work our programs and help us operate these programs throughout the week and the year. And currently we have about 62 paramedics and 21 basics that help us out. Next slide, please. A couple changes after the pandemic. So in early 2020, partnerships with some of our agencies to include STRAC, SAPD, Metro Health, the National Guard, and many other local community partners. We started COVID testing and later in vaccinations that following year. We created a systematic approach to using larger facilities such as churches, schools, community centers, gymnasiums, even parking lots to test and vaccinate the masses. We use this approach today with a lot of our community events when we still have these strong partnerships with these agencies. We use mobile integration to innovate individuals in the community that couldn't make it to these test sites. We were already doing this with a lot of our programs, so it was easy to integrate this into COVID operations. Of course, communication was key during COVID, and when we're using PPE, i.e. bulky gowns, gloves, N95 masks, respirators, it was difficult to communicate and collaborate the ways that we were used to. This birthed the development of technologies we still use today. One of these is an app that we use called Pulsera. Instead of radio and reports during COVID, we could use this to relay patient information directly to hospitals by an electronic device. Today, we use this technology in some of our programs, and if necessary, to do virtual medical consultations with our patients. Also, due to social distancing, we started using ways to do virtual conferences as we are today and meetings with apps like Teams, WebEx. This practice is now the norm for attending meetings virtually when meeting in person is unnecessary or inconvenient. Next slide, please. And again, here are 10 programs. We'll start with high volume utilizers, our first program. Next slide. Again, it started in 2014. This was a citywide program efficiency to resource allocate certain needs for consumers that were weighing down our 911 responses, our 911 call response. Since its inception, we've seen a 60% reduction in these calls with a 53% reduction in our top 100 HVUs. The team currently monitors about 130 clients at any given time. Next slide, please. As you can see, 2014, when we had one man working under HVU, we had 13 patients at that time that totaled about 138 runs. As of last year, we're monitoring 319, but we actually have a lot more HVUs. Excuse me, 319 that are enrolled, but we're actually monitoring a lot more, maybe triple that number, which translated over to about 1,260 total runs for that particular year. Next slide, please. This is the focus patient care cycle. It's the same cycle that we use for a lot of our programs. It could be catered to a lot of different needs, maybe in your community. The way this works is in this particular situation for HVU, we sign that patient up via phone or in person. The team meets with the patient, gets them enrolled, gets a HIPAA form signed. We do a basic patient assessment to include vitals, um, med recon, make sure they're taking the right medications, seeing the right PCPs. Then from there, we coordinate, navigate community resources. So this is where the magic happens. We have a lot of partners here in the city. A lot of it sparked during COVID. These folks will help us with anything that these patients may need, i.e., housing, maybe through the food bank, um, medications, maybe shelter. So they provide us with all of these items that these patients may need. And then after that, there's a weekly patient monitoring. We go see these patients weekly, make sure that they're getting what they need, and to prevent them from calling 911 unnecessarily. Some of these patients are still on our HVU program from 2014. We get calls from them regularly, sometimes 3 to 5 times a day. They call our 19 MH19, which is our 24-hour unit, and we talk with them and just make sure that they're good and they don't have to call 911. Next slide, please. Impact. Next slide. So this program is very similar to HVU. The difference is that it has a law enforcement component attached to it. The reason being that these individuals that are HVUs may have had a past history of violence or drug use, behavioral health. So we bring a police officer along with us to go visit these patients to secure the scene, make sure everything is safe before we interact with these individuals. This was also our first MDRT, or multidisciplinary response team. This model is used for a couple of other programs, as we'll see later in this presentation. In 2024, we've had 58 patients that were identified and addressed in the IMPACT program. Next slide, please. Hospice. Next slide. So this program, we currently have 9 hospice contracts. Under it, we monitor 450 patients in our census. The way this program works is that because we own the CAD, the 911 system, we're able to intercept any 911 calls to these addresses. Perhaps a family member came in from out of town. They're calling for mom that's transitioning. She doesn't look good. They call 911. They're worried. They want this patient transported. Well, sometime before this transitioning phase, this person decided that they wanted to pass away at home naturally and not at the ER. So what we do, again, we intercept that call. Our 24-hour unit goes out to this address, and we provide comfort meds. We provide care for that patient, and the goal is to try to keep that patient at home without transporting, if necessary, unnecessarily, I should say. Next slide. P-STAG, B-TAG. So these are our threat assessment groups. I'll start off with showing the short video. Next slide. Okay. So I'm not sure if there was audio there, but that was if you all remember, that was a shooting that happened several years ago, Sutherland Springs, about 20 miles south of San Antonio. Our teams responded. That was SAFD. We went down to Sutherland Springs during the aftermath to help that city with their EMS services. Well, while we were down there with law enforcement, there was discussions made with the top law enforcement chiefs and our chiefs on what we would do in this type of situation here in San Antonio, meaning conversations between different law enforcement agencies such as Bexar County, SAPD, or FBI, because we found that there was a lack of communication. So what these assessment groups do is they meet regularly. They talk about individuals that seem to be escalating in violence. We address those individuals and make sure that the next active shooter does not happen in our local jurisdiction. Um, the purpose of MIH in those meetings is we act as a medic. We're able to see certain medical records, medical runs that were made for that patient that law enforcement do not have access to. So we're able to provide certain information if needed to law enforcement to locate these individuals. Next slide, please. These are some of the agencies we work with in our TAG meetings, our threat assessment group meetings. Next slide. Acute care station. Next slide. So the acute care station is a program we started in 2018. Haven for Hope, 23-acre large, our largest homeless shelter in San Antonio. It was the #1 source for 911 calls. Um, our folks there in that area were getting hammered every night and every day, but generally at night, because during the day they have a clinic, Central Med, that's open and that address these individuals. But later on, after 5 o'clock, 5 p.m., they close. So a lot of unnecessary transports were occurring, a lot of unnecessary calls were being made to this location. So we collaborated. We started a program where we have a medic there after hours from 7 p.m. to 7 a.m. That clinic is open from 7 p. to midnight. After that time, that medic goes to a station that is nearby and monitors calls, intercepts any 911 calls to the Haven for Hope. The goal of this program is to see these individuals there at the clinic after hours, address those needs. We're able to offer any over-the-counter meds. These are low acuity calls to keep these patients there in their dorm. If they need to be referred to Central Med in the morning, we can do that as well. We also have a taxi voucher service. If these patients need to be transported to the ER, we can provide that as well. Obviously, if there is a true emergency, we can also add an ambulance to transport these folks to the hospital. Since its inception, we've seen a 77% decrease in these type of calls. Um, we found that during COVID, when it was shut down for a couple of months, the calls went straight back up to where they were, and then when we reopened, they went back down, just as they were previous to the COVID shutdown. So a very successful program. PIC. So this is the Program for Intensive Care Coordination, another MDRT, multidisciplinary response team that works with a clinician, SAPD officer, mental health unit, and a clinician from CHCS, the Center of Healthcare Services. These teams go out to the top 100 consumers that are usually behavioral health. They're emergency detained often. So these folks go out to these patients, make sure they adhere to their needs as far as seeing the right, making their appointments, seeing the right medical care, making sure they take their right medications. And the goal of this program is to make sure that they don't go into crisis and they don't go to the ER via ED. Molina Healthcare. So Molina is a managed healthcare program very similar to Humana or Blue Cross Blue Shield. They address Medicaid, Medicare individuals. This program started after folks at Molina heard about our HVU program and the success in it, they began seeing that they had their own HVUs, folks that were occupying the ER unnecessarily, of course, translating to higher costs for Molina. So they reached out to us. They send us a group of their HVUs quarterly. We go out and sign these patients up, very similar to the way we do with HVU. Make sure that these patients get what they need, just like we do with HVUs, whether that's durable medical equipment, medication, PCP providers, all of that, all of those things to make sure that they get proper care and they're not going to the ER unnecessarily. We average about 20 enrolled patients at any given time, and we collectively see anywhere from 45 to as high as 80 different calls for that particular month. SA Core. So this is a San Antonio Community Outreach Resiliency effort. Up until this point, I mentioned that all of their MIH programs were proactive. This is our first program that is a reactive program. It is also an MDRT, a multidisciplinary response team that works with SAPD and a clinician and one of our medics. Very similar to PIC. The only difference is that they respond to behavioral health 911 calls. These are folks that are already in crisis, maybe have suicidal ideations. They're calling 911. Well, our team goes out, talks with these individuals, make sure they get the proper care that they need, and they can also offer transport to certain facilities that our ambulances do not currently transport to, such as a behavioral health facility. And as of June 1st of last year, we have 3 units that operate 24/7, and it's been a very successful program. And the next programs are our polysubstance and our OPCR programs. I'm going to now turn it over to John De La Garza. He's the program manager for our substance use disorder programs.
Good afternoon, everybody. Thank you for having us, allowing us to present our programs here with everybody here in the community and in Texas. And so my name is John De La Garza. I am the Overdose Prevention Project Manager with the Overdose Prevention here in the fire department. And so one of the things that I want to echo as to what Lieutenant Guzman mentioned is that these programs are geared to reduce 911 calls. And prior to COVID, it seemed like the norm was that if anybody was injured or thought that they were going through a crisis, 911 was the one-stop shop to access to care. During COVID, we noticed that that norm continued on, and our systems became very overwhelmed, to include the hospitals. We realized during that time period, during COVID, that when we started initiating or started the process of addressing the COVID-19 crisis, we realized that individuals were needing to be informed as to how to manage the COVID pandemic and minimize overwhelming the 911 system as well as the hospitals. And so with that being said, we knew that the one-stop shop was oneself, being well-informed and educated as to how to manage and isolate to better develop a better care plan with themselves. And so with that model, our HVU programs identified that the 911 overuse dilemma in 2014, in 2014, when we started that, we're trying to figure out how we were going to do that. We paused our HVU program in 2019 due to the COVID-19 crisis. And then from that, we learned how to better develop these programs, given that we were now being proactive instead of mostly reactive to these crises. And we understood that it took a village to to solve these systemic problems. One thing, and in addition, prior to the pandemic, the U.S. had declared in 2017 the opiate crisis. And so due to that time period in 2017, where we were developing the overdose prevention program, that program also became paused during 2019 during the pandemic. And it gave us a time to reflect and understand how we were going to be able to approach these programs and better manage them. Since then, MIH has seen positive results in all our programs. One of the reports that just recently came out on January 15th, 2025, the CDC published a decline in overdose deaths from 111,451 deaths that were in 2023 of August to 86,678 deaths in August 24. So that was a reduction of 24,000 overdose deaths that were saved over that time period, showing that there is a model here that is showing some improvement with all these MIH programs across the country. Next slide. Okay, so yeah, hold up right there. So I'm just going to briefly discuss the polysubstance OPCR team. So polysubstance overdose prevention crisis team. This team is operational between 9 a.m. and 5 p.m. Monday through Friday, excluding some holidays and some extreme weather days. Our purpose is to visit residents who have overdosed within 72 hours from the time that a 911 call was made, and try to enter them into a continuum of services. The polysubstance teams is primarily trying to address anyone who is struggling with substances with alcohol, meth, cocaine, and potentially other substances that might be combined in there. When we visit with these individuals, we inform them and educate them on the risks of overdoses. We talk about the signs and symptoms of an opiate overdose, make them aware of fentanyl awareness of potentially drugs being adulterated with fentanyl. We teach them how to use Narcan, how to administer it, also teach them hands-only CPR. And then if someone is actively going through withdrawals, we will actually start providing treatment and managing those withdrawals while we're on scene. Once we're done with that engagement and we've managed, if it leads us to manage those withdrawals, we can determine with our medical directors as to whether this person needs to be transported to the ER, moved over to a detox facility, refer them over to a clinic, or at the very least provide peer support until that individual is ready. Let's see. So hold on to this slide right here. So now the OPCR team. So this is our second team. This is the Overdose Prevention Crisis Response Team. Originally, it was set up to just address opiate overdoses. And this team actually has 2 more days on their schedule. They are Monday through Friday, 9 to 5, and Monday through Sunday, Monday through Sunday, well, excluding some holidays and some extreme weather days. So along with this program right here, kind of mirror images some of the stuff that the polysubstance is doing. We also engage with anybody who overdosed within our 911 system within 72 hours of the time that overdose. Right now, I believe that we are probably meeting up with these individuals within 18 to 24 hours of the time of the overdose. We also inform them on the risks of using drugs, educate them on how to use Narcan, fentanyl awareness, pretty much the same thing that we do with the polysubstance team. Provide emergency transport. Also, we can grade down the emergency transport if it's not necessary, and get them to a detox facility, refer them to a clinic, and then also manage their withdrawals with certain medications. Next slide, please. So our teams. So each team is fitted out with 2 medics. And those medics, it's 1 paramedic and possibly one EMT, but there will always be 1 paramedic on the team. We also have an administrative team leader, which is myself. That person or myself oversees the operations. We do patient navigation. We collaborate with the community and our stakeholders into getting these patients into services. We also hold community events, and I also manage the logistics of the program. Along with that, we have three medical directors who assist us in treating these patients. So we do treat with a controlled substance. One of our MOUDs, medication opiate use disorder medications, which is buprenorphine. We offer the patient always a choice as to whether they want to be on methadone or Suboxone, or if they have an alternative way of wanting to manage their disorder. But if it comes down to it that we want to manage those withdrawals with buprenorphine, we contact one of our medical directors who is on call 24 hours a day. Even though we do have our team operating between 9 and 5, occasionally that 24-hour unit that Lieutenant Guzman discussed earlier, they can also be deployed to manage those withdrawals. With that team, we have noticed that that team will also get deployed to that shelter, that the Haven for Hope, where occasionally that population sometimes comes in having withdrawals, and we can manage them and then bridge them over the next day into treatment services. Next slide, please. So this is a picture. Nope, back up. Yeah, so this is a picture. The overdose prevention team, all of MIH is centralized in that building up on the top right-hand corner. That is our headquarters. It is not a clinic, so we do not accept patients there. Our purpose is to engage with these individuals out in the field, and that model was stemmed off from our COVID-19 operations. On the left-hand side, you can see two of our paramedics in one vehicle where they're typically going out into the community and engaging with these individuals. Our medical director, he also goes out mobile, and so that is his vehicle out there. If you ever see him out in San Antonio, he's probably meeting up with some of our patients and making patient contact. And the right-hand side, you can see where we're actually making contact with our patients out in the community. Next slide, please. So our referral process, it comes in typically with 911 overdoses. Anyone who overdoses in the city is screened there in the office by myself, and we formulate a plan for that same day or the next day for a visit for the team to go out and visit with them. We also receive referrals through our dispatch system. So between the hours of 9 and 5, if someone is actively having withdrawals, typically because we have been out in the community, they have heard that the fire department is managing those withdrawals. So they'll call our dispatch, and then our dispatch calls us at our office. We also, when we go out to engage with these individuals, we leave business cards if they're not home, and through word of mouth, sometimes they just give us a call or text us on our phones there in the office. And then internally within our fire department, if someone is actually actively going through a withdrawal, they can use that QR code and refer them over to us. Not to mention, through those self-referrals, because we are working with our stakeholders and our community partners, we also receive referrals from our homeless resource hubs and some of the religious institutes where we partner up with. Next slide, please. So this slide right here is just the borders of Bexar County within the city of San Antonio. And the way we do operations, and I think that this would probably be beneficial if another fire department decides to start an MIH program. We section off our city based on the stills of the San Antonio fire stations. And so when we deploy our teams are well aware of where all the fire stations are, so they can maximize their contact by us isolating that team to target one area where we feel that overdoses have been prominent. If we don't meet up with that patient after the first 24 hours or 72 hours that we try to engage with them, then we keep a record of that individual being in that area, and we typically go back about 5 times within that area over a course of a week or so to try to see if we can engage with that individual. So it's not if we don't meet up with them the first time, it's not that we drop them. We continue on until we finally hopefully meet up with them, or they get word that we were there. The benefit of deploying the teams out to these areas like this is the fire stations who are making these runs. They're a wealth of knowledge and resources to helping us out identify where this individual might be. So it increases the ability for us to engage with that individual. Next slide. And so as you can see right here, this is one of our vehicles that is outfitted with the equipment that we go out and try to engage with this population. And so with this group or with our team, we do carry pretty much everything that an ambulance is outfitted with. So if we ever do come into an emergency situation, we can initiate the 911 system and immediately start managing the individual in the capacity that any ambulance would. And then we would turn them over to the ambulance and get them transported to a hospital. Next slide. So this is a Narcan kit that we leave behind. This is a leave behind informational guide and Narcan on how to use Narcan. Anybody who is not necessarily ready for treatment, then we definitely want to make sure that they are aware of the services that we're providing to them, and then also how to use Narcan. Next one. The signs and symptoms. So I'm not going to go too deep into this, but this is part of the educational guide that when we meet up with them, we teach them what to look for when there's an active opiate overdose. This is also to inform our community with people who might be living in an area where they see overdoses or overdoses are prominent in that area. So this is for our community as well as for our patients that we engage with. Next slide. Narcan, we use the same model that Narcan teaches out there, lay, spray, and stay. So this is just a picture of what we're educating the public with. Next one. And as always, we encourage everybody to call 911 for at the minimum to hopefully maintain continuity of care with this individual in case they overdosed on an opiate, but even better yet for us to be able to reach out to them post the 911 call and get them into services. Next one. We do teach hands-only CPR. There has been a concern regarding to some stranger wanting to save a life, and so doing mouth-to-mouth is something that people have frowned upon with someone who they do not know. So we do teach them that hands-only CPR is a good method of providing respiration, circulation of the blood within the patient until we get there or an ambulance gets there. Next one. And we have had an increase of questions in regarding to what happens if I provide a CPR or administer Narcan and the individual dies. Would I be responsible for that death? We do encourage them that being a good Samaritan and administering Narcan with reasonable care, that they would not be subject to criminal prosecution. And so with that being said, we encourage everybody to use Narcan at the very minimum and call 911. Next one. So part of our buprenorphine induction out there, when we start managing withdrawals, the medics would do a basic physical assessment. We got a clinical opiate withdrawal scale that we measure out their withdrawals, and then ask the question as to when was the last time that they used any kind of drug, not just heroin, because of the potential of there being fentanyl or something being adulterated with fentanyl out there. And so anybody who has not used drugs within less than 24 hours and has a COW score of greater than 8 meet criteria for buprenorphine treatment. If they're on methadone, then that's a long-acting opiate. and therefore that will require probably 3 to 7 days of a washout period or abstinence from getting induced with buprenorphine. In the case of them having to have used within less than 24 hours, we do provide a comfort care pack, which encompasses Zofran, Benadryl, Imodium, and we do use clonidine as a means to somewhat minimize their withdrawals to prepare them for treatment, hopefully within the next day or after 24 hours of their last usage. Next slide. And so this is just a picture of our COWS score. We measure out the resting pulse rate, whether they're sweating, restlessness, measure out their pupils. If they're having achy bones or muscles and other symptoms that go along with withdrawals. At the time that we collect that score, we call our medical directors, we report that or relay that over to our doctor, tell our doctor the last time that they used, and then give them their vital signs. And as long as there is nothing within their medical history that prevents them from receiving buprenorphine, our doctor will typically authorize a certain amount of treatment or dose of buprenorphine, and hopefully they get a good experience so where we can come back and visit them the next day. Next slide. And so some of the exclusion criteria, as I mentioned earlier, are opiate use within 24 hours. Our criteria now, that's changed a little bit. Any drug use within the less than 24 hours, we're not going to treat with buprenorphine. And like as I mentioned earlier, methadone is 72 hours or more before we can even attempt to start treatment with buprenorphine. Chronic pain, patients who are being managed already by a doctor, sometimes we stray away from that. We're not addressing an opiate disorder at this point. And so many times when we come up to a patient who might have overdosed on an opiate, maybe because they took a little bit too much, but they are being managed by a doctor, then typically they will decline any services from us only because they're already with a doctor. Any indication of intoxication or other substances being used at that point, especially with benzos, that can be fatal with being treated with buprenorphine. Typically, we will offer a detox option, or if not, try to manage their withdrawals with the comfort meds until they do meet criteria for bup treatment. Currently, our doctor usually makes the decision and says, yes, we will treat patients who have an opiate use disorder and a history with 911 with opiate use, even if they're pregnant. And then we quickly try to get them into a clinic within 24 hours or the same day so they can start being managed a little bit better with a higher level of care. The presence of severe cirrhosis, many of our patients, due to the fact that they are sometimes IV drug users, they run the risk of having cirrhosis or hepatitis C. We manage those and try to get them into a higher level of care as soon as possible as well, in hopes that by getting them started on buprenorphine, we can do a harm reduction effort at that point, and then have a doctor take over their care. And then obviously unstable vital signs. That's if that's going to quickly escalate to probably a 911 call and get them over to the hospital as soon as possible. Next slide. And so quickly, this is just a film of buprenorphine and how to administer it. It goes in the buccal area or underneath the tongue, and we leave it there for a couple of seconds, and patients typically say that they find relief within a couple of minutes or in about 30 minutes from the time that we administer it. Next slide. And then, like I said earlier, our criteria is we don't administer buprenorphine to anyone who has used any kind of drug. Meth is is the next growing drug within the city here in San Antonio. And we're finding out that meth is being laced by fentanyl. So that would be an exclusion criteria for getting started on buprenorphine. Next slide. Here you can see some of the drugs that are being adulterated out there. You have benzodiazepines over there, heroin, marijuana, the vape pens, meth bottle down at the bottom. You can see cocaine and fentanyl that are both white. So sometimes they speedball that, and then now they're pressing pills that look like those M30s, which could be fentanyl or who knows. They're not measured outright, and so they're people can, sometimes we can't even tell the difference. So if we encourage them not to be buying anything that's over the internet or on the black market, because you never know what you're going to get. Next one. And like I said, this does take a village. These are some of our stakeholders here. We have clinics, we have peer support organizations, mental health organizations we all work together. All of this came together back in COVID when we were dealing with mental health patients. And now it has evolved to now where we are addressing overdose prevention. And we're still collaborating with all these partners in our community. Next slide. Here is some data on in 2024 with our retention patients that we've referred at 30 days. With our patients that we've referred, 83% had remained in the clinic. 60 days, 67% were still in the clinic, and then at 90 days, 50% of the patients that we had referred to the clinic were still in the clinic. So that was great data and great for us to see that our efforts were working. Next slide. Between the two teams, we see 235 patients per month from 911 calls that meet criteria for services. Of those, we make contact with 100 per month. On average, 30 of those are referred to peer support, 26 to one of the clinics, and about 20 are bridged into Suboxone. So between those that go to Suboxone and 26, those are either going to methadone or Suboxone. Next slide. Okay, and so now we'll go ahead and open it up to anybody who has questions.
Thank you so much, Officers De La Garza and Guzman. This has been a great presentation, very enlightening. We're happy to see that we can count with a team like yours here in San Antonio. Great job. I see already some accolades from our participants on the chat. Someone is saying, this is amazing. Congratulations to San Antonio and this team for getting this program up and going. So thank you. Thank you for giving us the service here in the community. And I think we have time for a couple of questions. I see here someone saying, could you elaborate on unnecessary call? Does it mean additional or more scrutinizing of calls to determine what resources are in need for dispatching? So just to clear up a little bit more what you would call unnecessary calls, when you say that the service, your great service that you're giving to the community is trying to reduce the amount of calls, what is the goal specifically on doing
Absolutely.
so?
So let me use the acute care station as an example that comes to mind. So a lot of these low acuity calls, which we call them, it might be something as small as a allergies or like minor allergies or maybe a low grade fever. Some of these individuals will call 911 because they don't know any better but to call 911 for a service. So again, this takes an ambulance away to cater to this. I don't want to say it's an unnecessary call, but it can be dealt with in a different fashion. And again, at the acute care station, we would be able to offer over-the-counter medications, maybe like Robitussin, cold medicine, an allergy medicine, something like that, where some of these individuals may not have that access to those particular medications, and we could provide that to them rather than having an ambulance go out to them and transporting them to a hospital or an ER for these type of calls, low acuity calls. Hope that answers that question.
Yes, yes, absolutely. I think that that's exactly what we were trying to figure out. And there's also someone here asking, can you share any specific success stories where your team's interventions have significantly improved the patient's outcome? Any success stories? I'm sure you have several.
Yeah, but
Yeah.
many. I'm gonna let John you talk about some of
Okay,
his with his substance use disorder individuals.
So
sure.
one of them that comes to mind is we had an individual, and there was a question on the chat as to how far do we respond, or are we just within the city limits, or do we respond to outside of the city limits? So to answer that question, we only respond within the city limits, but what's been happening is the word has been getting out to people outside of Bexar County or in other counties. And personally when it comes to an individual outside, we had one individual who was a veteran within the military, well known within his community, was actually running for city council, had an opiate use disorder, and was actively going through withdrawals. He heard about us. He called me directly on my cell phone because the clinic that he was going to be going to go get treatment was not the clinic that he felt like he needed to go to. And so he reached out to us. He personally drove over to headquarters, and I did mention that we're not a clinic at headquarters, but he drove over to headquarters, and we could not deny him services. And so right there and then we treated him. He went back home to his family. We bridged him over to the clinic. He got engaged with the clinic. And then ever since then, he has always been reaching out to us at least twice a year, letting us know how much he was appreciative of what we had done for him, and how he, how much a better father he is with being, not having to deal with those withdrawals or those urges or the depression that he was dealing with PTSD. Given that we had started him off with buprenorphine, he did mention that at that time, if he would have not gotten treated, he might have had a reoccurrence, and who knows, he wasn't sure if he would have been able to have gotten into treatment. So even after 2 years of starting off with us, he still calls us and lets us know that he's still very appreciative of our help. That's just one of them out of many that I can remember.
Oh, that's great. Thank you for sharing that with us. And someone here is asking how frequently or how often you access or you offer your help in rural areas. We know that there are always challenges with certain areas where the access of care is very limited. How do you guys deal with that?
So with the overdose prevention program, because we're utilizing some of the technology that helped us out during COVID, which is virtual visits, or home visits, these patients that are living in the rural area, sometimes they will come into San Antonio and meet us at a fire station. If they were a 911 call and they were in the city limits at the time that they overdosed, but they don't live in the city limits, but we ended up calling them to find out if they were interested in services. Typically, we'll ask them to come in and meet with us, and then we'll refer them, and then they get those virtual visits through the clinic. So doing virtual visits or telehealth has gone a long way in minimizing unnecessary 911 calls, not to mention ER visits.
Right. And also, we have a consortium of MIH, other agencies around that border San Antonio that participate with us. So they also go out to these rural areas. Some of these folks are, for example, Schertz or surrounding counties that they can address some of those individuals that have MIH type needs.
Thank you. And someone here, another accolade. This is an awesome team. This is one of our participants saying, thank you for meeting clients where they are and not allowing them to fall through the cracks to the best of your abilities. The community level of, the level of engagement that you offer the community is indicative of your awesome attention to service provision. That's
Thank
great.
you. Thank you very much.
Wonderful. Okay, so we have some other questions, and but in the interest of time, maybe we're going to start moving towards the announcements. And we want to thank once again Officers De La Garza and Guzman for sharing with us their experiences and the incredible service they're offering to the community. Please remember that we're going to be sharing this material with all of you at the end of the session. But very quickly to the announcements, we want to remind you that CSTAT offers technical assistance. And if you're interested in technical assistance, all you have to do is go to our page at cstat.utesca.edu/contact. There is a form there, and once you complete it, someone will get back to you in approximately 3 days. So please use this service. This technical assistance is completely free to everyone in the community. Next. To claim CMEs today, please text the code ATTEND 100-98271 to the phone number we're sharing with you in the chat. That should be enough to obtain your CMEs. But if you're claiming certificates or your CEU credits, what you have to do is make sure that you answer the post-session survey. We're sharing it with you in the chat, and we will send that survey also via email after this class. Should be receiving your certificates somewhere between 2 and 3 weeks after this class. Next. And we still have registration tickets available for virtual participation. All our in-person tickets have been sold out for the Texas Substance Use Symposium, but you still can register for virtual classes. So still on time. So just go to texas.org, that is txsus.org, and you can register there for virtual participation. Next. If you or your organization are interested in being sponsors or exhibitors for the Texas Substance Use Symposium, you still can do that. We have a variety of sponsorship and exhibitor packages still available. Just go to texas.org/sponsor Texas. Next. And meet us here in this space for the next webinar session. That's March the 20th. If you haven't registered, you're still on time. You can go to our webpage. We're sharing it with you. And we'll see you here March the 20th at noon. And that's it. And we want to thank again our speakers and all our learners for the questions and the comments. We're going to see you next month. Have a great rest of your day.